let's take it. So now, actually at the risk of having a little excess of me, this is a topic which is actually quite dear to me. I genuinely feel that it is a subject which is very often neglected. It is a subject about which a lot of my colleagues and maybe even ourselves we know very little about it. And there are many reasons for that actually. When I wonder, see, when we are in medical school, we generally, most of us have come out from government medical schools where the kind of patients that are treated are often very indigent, they are poor, and they cannot really afford parenteral nutrition. And so what we see in medical schools and what I have seen and what I still see my younger doctors who emerge from these medical schools practicing is a little bit of protein supplementation, a little vitamin, or a little hermine here and there in order to buttress their protein supplies. So that is the kind of nutritional awareness that we have today. And I genuinely do feel, and there are studies to prove that you do reduce the risk of complications following surgery and even otherwise medically ill patients if they are properly nourished. Nutrition, I'm not a nutritionist obviously, and therefore I would possibly, my knowledge about nutrition may be definitely more limited than that of a nutritionist, but then I would possibly be able to give your clinicians and a surgeon's perspective on it. And I would be talking, for the sake of time, more on parenteral nutrition than on the enteral component. My talk over the next 20 minutes would be under 4 basic headings. We would be talking about how to assess the nutritional status, some of the pitfalls that we encounter when we use some standard methods of nutritional assessment. How do we plan for parenteral nutrition? How do we monitor a patient who is on parenteral nutrition? And then what about the complications when we are administering parenteral nutrition? Now obviously, assessment of it, the ABCD formula, there is anthropometry, whereby the height, the weight of the patient, the body mass index, and the skin fold calipers are important. You have certain biochemical tests with albumin and other visceral proteins, the WBC counts. There are certain clinical parameters, and I will be dwelling on this a little later, like the subjective global assessment. And then of course the dietary record, the food record, and how the patient has actually been eating over the last maybe few days or months. The body mass index is used to estimate the body fat mass, and it is derived from an equation using weight and height. So if it is very low, you know that this patient is probably not, is malnourished. Skin fold measurements, as you know, would actually be done at the level of the triceps or the subscapular regions. And that would give you an idea as to the amount of body fat. However, I would like to issue a note of caution, because none of these measurements would actually be foolproof. In fact, if one was to go by this, then maybe the father of the nation who defeated the British Empire would be considered an extremely malnourished person, which I'm sure you would agree with. We have a lot of visceral protein, so we often rely upon to assess the nutritional status of the patient. You see, very often we come across where he has an albumin of 1.8, so obviously he is grossly malnourished. Maybe he is. But there is a problem with this, because a lot of these visceral proteins do actually fall in conditions other than malnutrition. For example, if a patient is having severe sepsis, his capillaries tend to be very leaky, and even within a day or two, his albumin levels are going to fall precipitously. His nutrition would possibly be perfect. So if you are going to rely entirely on these visceral proteins, there's going to be a problem. Albumin, of course, is very commonly used, and therefore I would like to stress a little more on that. This is a visceral protein with a fairly long half-life. It has a half-life of about 20 days. So it will take a long time. So if a patient is actually not, is malnourished, is having acute nutritional deficiency, it will not really reflect in his albumin levels till they actually, they say till about a month or so, or maybe 2 to 3 weeks. So ideally, we would require a visceral protein which would have a short half-life and which would not be affected by the conditions. As you can see, there are other proteins like serum transferrin levels, prealbumin, and retinol binding proteins, which have much shorter half-lives. And therefore, they do not have this problem of actually having for a patient to be malnourished for a long time before they actually fall. However, most of these visceral proteins, as I've said, can leak through the capillaries, and in patients in severe sepsis can always pose a dilemma. There is this, what is called the creatinine height index, whereby it, the urinary creatinine excretion, 24-hour urinary creatinine excretion would be standard for a given height. And if it is low, then one possibly would think that the muscle mass of this patient is a little low. So this is another way of actually assessing the nutritional levels. However, once again, it has its flaws. There could be patients with kidney problems, and in those cases, it may not be the right way to assess.